Well, here we are in Kibera, just on the outside. Kibera is an old community, actually. It was put together as sort of a gift to those who had supported the British colonialists way back in the early 60s, and at that time was known as Kibera, which means forest in Nubian. And after the early 60s, people just started streaming into Kibera, and it's become a melting pot for people from all over the country, representing essentially all the tribes in Kenya.
Africa is rapidly becoming urbanized. As more people come into the cities looking for work and education for their children, the infrastructure for services just cannot keep pace. Informal settlements like Kibera have sprung up all over Nairobi. Current estimates are that more than 60% of the Nairobi population, which is about 5 million people, live in similar settings, notable for dense population and problems with adequate clean water and sanitation. CDC Kenya was not doing surveillance work in an urban area in Kenya when we started our program in 2004. When we began our Emerging Infections program, we felt that urban slums like Kibera could provide windows into how dangerous, new, or common pathogens could spread, threatening the health of large numbers of people.
Over my shoulder is the new Tabitha Clinic, which just opened about a month ago. It's been a couple of years in the making, and it's right smack in the middle of the surveillance area. And so everyone in our surveillance area, the 30,000 people that we do surveillance on, lives within, no more than a kilometer, much closer to this clinic. And they can access it very easily. And it's currently seeing about 200 to 250 patients a day. So this clinic is called Tabitha Clinic, and it's operated by Carolina for Kibera. We at CDC and the Kenya Medical Research Institute provide the clinicians, and there are about 7 of them, and nurses and laboratory technicians and pharmacists, and we provide a steady supply of drugs.
My name is Dr. Henry Jenga Juguna. I'm the medical officer in charge, and also I do facilitate the issue of research and data collection. Being a medical officer, my main work is to supervise my clinicians, ensuring that they collect data and they collect it accurately, and ensuring that the protocol is well followed. This project has helped us gather a lot of information. One, we've collected data on the most prevalent disease conditions that affect the people of Kibera. Then we've also established that what was thought not to be common in Nairobi, that is malaria, we've actually seen quite a number of patients who have malaria within this facility, and they have no history of travel to malaria endemic areas.
The surveillance area in Kibera includes 2 villages with a population of about 30,000 people. Every 2 weeks, a group of 20 community interviewers, which we call CIs, visit each home in the surveillance area and collect information using personal digital assistants, or PDAs. They collect detailed information about each illness of residents in our surveillance area. Since we began the project, the CIs have collected more than 2 million records regarding the health of the people under surveillance. They have to find their way through the low roofs and negotiate mud brought on by sewage drainage and rain, sometimes brutal heat, and contend with a variety of day-to-day surprises to collect these data.
There is constant surprises and constant new knowledge from our work out here. When we first got here in 2004, we were told that influenza was not really a problem in sub-Saharan Africa. Our surveillance work here in Kibera, and also the similar project that we have in the rural area out in the western part of the country, has shown that influenza is a very, very big problem here, and that it's quite seasonal. It occurs during certain months of the year, really the cold season. And in this location in Kibera, where you can see over my shoulder the dense population of people living in very, very close quarters, we're able to look at how easily influenza is transmitted. The issue here is that if a new strain was to appear, and was spread to people living in Kibera, you can imagine how it could be transmitted, how rapidly it could move, and affect the people living in such a densely populated setting.